All right, thank you for staying with Daybreak. Now we have a conversation on the medical crisis that's in the country right now. Or is it? That's a conversation we're having. Peterson Wachira is here, Kenya Union of Clinical Officers Chairperson. Nicholas Odipo, Kenya National Union of Medical Laboratory Officers Chairperson. Dr. Muinde Ntusi, Medical Officer Intern. And Kennedy Okongo, Medical Credit Fund Director, East Africa. Thank you so much for making time. Now, Wachira, I'll start with you. What is the current status? Are you, as clinical officers, are you all on strike, or is it certain regions? What is the current status right now?
Trevor, we are on strike, and today we are doing day 47. This is by far the longest strike by clinical officers since independence in this country. And we are in this not because we actually wanted to be on strike, but because the employers and the government wanted us to be on strike. And I say this because we came together as all the unions on that March, and we wrote a petition to all the concerned parties, all the unions in the health sector, including my brother here, Davji from KMPDU, and we asked the government, that is the ministry and the county governments, and even the treasury and the other offices, that there are these challenges we have. Can we sit down and resolve them? But they didn't. And then that is when it was followed by a series of strikes. Of course, the doctors at the expiry of the 14 days started. We joined 14 days after, together with the lab. And the others probably didn't join, but also are aggrieved. And the reason I'm saying that it's the government that has actually driven us into this. And I don't understand what they intend to gain from this. Because even the prolongation, by the way, is from the government, is that there was a court order in our case on 8th of November 2023 that actually had directed us to come together, sit on the table, and conclude the CBA. And while the Ministry of Health came to the table, the 47 county governments didn't come to the table. And that is why we found ourselves on strike, not because we wanted. But now we find that we find ourselves there. Then it becomes very difficult for us to call off the strike until the issues that we put forth are resolved. Because they have shown us that, number one, they do not even respect the court. They refuse to come to the table in the first instance as an employer-employee and negotiate a CBA. Then when they're ordered by the court, they do not come to the table. So if we were to go back and call off the strike for people who do not even obey the law, are they really going to come to the table? And that is why we are still on strike, and we'll continue on strike for as long as our grievances are not addressed. Yeah. Our strike is protected, and this was buttressed by the court. The other day, the Labor Relations Court gave orders prohibiting the employers from harassing, from disciplining, from stopping salaries, and they summoned them to the table so that we can be able to negotiate. So after that, now the Council of Governors has come to the table. I think we have held 2 meetings, but we are here to agree. And even in the Ministry of Health, because we had seen goodwill. And when we started this strike, you remember we said, because we do not want Kenyans to suffer, yeah, we had left a part of our membership under the Ministry of Health to provide the critical services. Yeah. But then there is a lot of delay in these negotiations, and now we decided to withdraw them from those hospitals, especially Mathare, Spinal, Port Health, those working in KNH Othaya, and also those working in KUTRH, because we are not seeing that urgency in resolving our issues. Okay. And Trevor, you know, sometimes when we talk about our issues, people think that probably we are self-seeking and probably we are selfish. But let me start from the story I gave you, which is not a story actually, it's the reality. There are people who are really suffering, and even mentally, health workers, because of the type of engagement they have been given by the government. Mm-hmm. If you look at the law, Article 27 of the Constitution outlaws discrimination of any kind. Yeah. But when it comes to the workspace, that is provided for under Employment Act, Section 5, it talks about discrimination at the workplace. And it says that if you have two groups of people performing work of equal value and you're paying them different salaries, then you're discriminating them, which is outlawed.
Yeah.
But then you have these UHC cohorts who are earning half of what the others are earning, and then you are being told, can you sign a return to work agreement that is going to continue propagating that they continue in the same terms that even the Constitution speaks against. The other day, because we have some laboratory officers and clinic officers who are engaged by the Global Fund together with the ministry on a project on TB, National TB Program, that is the name. They have been there for more than a decade. In their contracts, they were supposed to be absorbed at the end of the contract. The contract expired in January. There was no communication from the ministry. One of them, who is a clinic officer, and a lady called Gladys Ribui, who we buried in Hubuine in Nyeri County, she fell into depression. She took her life and that of her child. So when we are fighting for these things, it's a matter of life and death. We are fighting so that the health worker who is sitting on the other side when they are seeing you,
yeah,
they are mentally sound.
Okay.
And you know, when we're also asking for things like, can we employ more clinic officers?
Yeah.
Trevor, I have given this story, but I'll give it again. During the time of COVID, I almost lost my dad because at some point he caught COVID, went to several hospitals, was seen by a clinic officer in one, was seen by a doctor in another. They never diagnosed. In a 78-year-old man, they never diagnosed that he was having difficulties in breathing. When I realized this, because I could tell when I was calling him, then I told him to go to the referral hospital in Nakuru, the Nakuru PGH. In the first time he went there, they actually never even took a COVID test or realized that this man was having difficulties in breathing.
Yeah.
They just look at the other comorbidities that he was having. Now, by the time we were admitting him, his oxygen levels were really going down. He couldn't even use a phone. He was really going down, and the lungs, almost 68%, was destroyed. Now, I decided to go back later and audit and find out what was happening. Why would anybody miss something that was so obvious? When I went to Nakuru PGH, I found that on average, one clinic officer sitting for 8 hours sees between 100 and 150 patients. You know that is witchcraft. Even in magic, you cannot do that.
Yeah.
And so, the fatigue and the burnout that is facing these people, yeah, is actually making us misdiagnose. Because if you look at burnout, the symptoms of burnout from a basic Googling, yeah, you'll see issues of poor attitude, irritability, mental cloudiness. And this is why sometimes we are getting people misdiagnosing people, not because they are not competent, yeah, but because we have a shortage. So when we're asking for them to employ more, yeah, we're actually helping that patient so that they get the right diagnosis and the right treatment, and so that they do not get the complications.
Okay, we'll get into the details of what your ask is. But Odipo, what is the current situation for the laboratory officers? Are you all on strike? Are there some that are working? What is it?
Trevor, we are all on strike. And today is the 45th day that we are on strike. There are some that we left at the hospital to do the emergencies. But I think we are going to call them out so that we have total paralysis. Because in our case, it is very unique. Our issues on the table are the most simplest issues that a willing government, a working government, a government which is eager to provide services to its citizens will have listened to us even before we went on strike and dealt with those issues. But now we are on the 45th day of strike, and the government has not called us, both the county government and the Minister of Health.
So the lab techs have not had a sit down at all?
We have not had any sit down with the COG. And that is why we now want to paralyze everything. Actually, we had left part of us that were dealing with the blood transfusion services to be at work, so that the people who will be going to hospital in private sector can access blood. But now where we have reached, we are going to paralyze everything so that there's not going to be, people are not going to get that blood, whether in private or in public hospitals.
Yeah.
Because now we cannot be treated in contempt, and you expect us to provide essential services, critical services, because blood is a critical component in healthcare services. And without blood, even the theaters will not be operational. But they were called, the other day we were called at the Ministry of Labor for a conciliation. They did not show up. We again went there, we were told by the Senate to take a certain letter there. Now, we are even more worried that 1 week after taking that letter to the Ministry of Labor, the Ministry of Labor have not communicated to us, telling us when are we getting that conciliation meeting again with the Minister of Health and the Council of Governors. So to me, Trevor, I just think that we have insensitive people in government, and the citizens themselves, it is up to them now to start calling out their leaders.
Yeah.
If the citizens decide that for them they want to sit back, this issue is not affecting them, they are very wrong. And I have to tell them, this issue affects you so much.
Okay.
Because there are people who cannot afford private hospitals.
Okay.
They are dying in the villages. And you voted for these people, these governors, the president. And the president appointed a cabinet secretary. A cabinet secretary who is discriminating amongst cadres. Because how do you tell people that you've completed discussions with our colleagues at the KMPDU? They have started communication or negotiations with our friends, the clinicians, and the lab, they have not given them any time.
Okay.
So maybe to them they see that the lab is not all that important. But I have to say, lab is very, very important. And wait, we get out our colleagues from the blood transfusion centers.
Yeah.
Then things will go wayward.
Okay.
Because even the private hospitals depends on the Kenya National Blood Transfusion Services to give them blood.
Okay.
So the moment we will withdraw that, then God forbid, any government official who will need blood will have to get his matters right.
Okay.
Yes.
Let me bring in Dusi on this before I bring in Kennedy. So your union, the Kenya Medical Practitioners and Dentists Union, called off their strike.
Yes.
But there seems to be a bit of a disgruntled voice from the interns. What is the situation? Are you happy with this situation? What's happening from the interns' perspective?
Well, I speak on behalf of the 1,360 medical officer interns, dental officer interns, and pharmacist interns in this country, and also the young doctors who are also represented. The challenge is, with each and every strike that's been there before, I'd even quote a more recent one, the 2017 strike. The resolution of the strike led to ideally spread out or trickle down benefits. I'd really equate the healthcare profession to like a military, the military organizational structure, in the sense that you have frontline soldiers, so we also have frontline workers, and interns and young doctors. Interns who are young doctors are actually the frontline workers. So these are the people who bear the brunt of the work. And when I speak of the brunt of the work, I'm talking about ideally 70% of the workforce, or rather the work that we should actually be doing. And you see, it's a bit different. When you think of a typical 8 to 5 job that people usually have, for interns it's completely out of the question. I mean, we talk about 48-hour shifts and 72-hour shifts. And let me even put things into perspective. and equate it to the value that we actually bring. When you look at a procedure, like let's say cesarean sections, because we really need to speak about the growth of our country, each and every cesarean section in public hospitals, according to a recent article that was actually released by Citizen, costs between 50,000 to 100,000 Kenyan shillings in government hospitals. And it's interns who usually conduct these procedures. And you don't just conduct one procedure in a day. The extremely busy weekends and extremely busy shifts where you can actually conduct to the tune of 20. So you can imagine you basically being the person in charge who receives the patient, you prepare the patient, you take them to theater, you operate on the patient, you keep track of the mother and child afterwards, and the value that you're actually bringing, or rather the value that you're creating, it can't actually be equated to what you're being compensated. I mean, let me be honest. The amount of money that was bargained for under the 2017 CBA was 206,000.
Yeah.
And the truth is, if you were to equate it to the kind of work that we do, the complexity of it, and I'm not saying this to demean other professions or even other interns. No, I'm just comparing and contrasting in a sober way while quoting facts and also giving figures. It's quite a lot, and it is complex. It's complex work. We've spent 8 years. I've been in school for 8 years, and each and every day, it's almost as if, because medical school is tough, it almost makes you question whether you want to be there. But it's a calling, and we persevere. And it's something that we tell ourselves each and every day, because we yearn to serve this country. We yearn to treat people. We yearn to make people get better. But then it's quite difficult to expect us to do that when you're actually going and the amount that was actually agreed upon by the government, signed, because there is continuity in government, is actually being taken away from us.
Yeah.
We're talking about the current economic time and how difficult it is to survive, even with the existing state. And then having a 70 to 91% pay cut, I mean, it's quite punitive.
Okay.
And you see that the challenge is, as young professionals and young doctors in this country, there's a lot of responsibility that we shoulder. We take care of our families, not only the ones that we are born in, but the ones that we have.
Okay.
We have children, we have people who we need to feed. So how do you go for 48-hour shifts, 72-hour shifts, and come home empty-handed with nothing? You can't even feed yourself, you can't even pay rent, you can't even buy, or rather even have insurance for yourself.
Okay.
You can't even afford the services that you're giving to people. And that's the issue that we have as interns.
Now that KMPDU called off the strike, do you support that move or not?
Well, it's complex in this regard. We support it because unity supersedes all.
Yeah.
And our union is what makes us who we are. That's why we have a collective bargaining agreement. But it is expected. Sometimes people have disagreements. You could say it's a generational thing.
Yeah.
You could say, you could equate it to, or rather attribute it to various factors.
Yeah.
But the truth is, we did feel disappointed. That is true. But that doesn't mean that our disappointment and our honesty and the fact that we feel that the windfall didn't spread out to us, that we've broken away or we are mad. No, the union told us that they had a sit down with government,
yeah.
And even with the president, and he gave them the assurance that once they call off the strike, they'll address our issue.
Okay.
And so just imploring the decision makers, the president and the government, to actually address our issue within the 60 days that they actually stipulated.
Okay.
Yes.
Let me bring in Kennedy on this. Kennedy, as this crisis is being felt everywhere, there's a clinical officer strike, there's a doctor strike, there's the laboratory tech strike. How has this impacted the private health facilities?
Trevor, let me take you back to sometimes last year when an act of parliament knocked out NHIF and introduced what we call SHIF, or Social Health Insurance Fund. Immediately after that, we also, you people reported a hospital being auctioned in Eldoret. This is one of the biggest private hospitals that we have in the country. And they were being auctioned because they were unable to pay their bills. They were unable to pay their debts. All these private hospitals that exist in this country to supplement the government hospitals operate in one way or another from borrowed funds. When they see patients relying on NHIF, relying on insurance, because our out-of-pocket expenditure on health is very minimal, again, looking at our incomes. So when the National Health Insurance Fund, which collects these monies on a monthly basis from me and you, and now is proposing to actually increase that collection from a certain amount to an even bigger amount, cannot reimburse the hospitals that are providing a service to the citizens of the country, then that becomes a crisis. One, it becomes a crisis to the citizens of the nation who are affected directly or indirectly. Because, Trevor, how many Arambes can me and you do to ensure that everybody goes to hospital? And yet we are having these deductions that should go towards health. Now there is a stalemate because there is a transition. During the transition from NHIF to SHIF, claims are not being paid. Already we have doctors on strike in the public sector. So that side, there is no treatment coming. So the small private sector that is left that we are trying to support, for example, as medical credit fund, by availing them debt, they cannot repay these debts. Recently, I saw it from the Monetary Policy Committee of Central Bank, saying that we've reached a record high on non-performing loans in this country. They was talking about 15, 16%. Trevor, that's not the reality. The reality of non-performing loans currently is going to almost 50%. If all financiers could come on the table and put the facts, we are hitting 50% of non-performing loans. Yesterday or the day before yesterday, again in the Business Daily, we're seeing like 97% increase of the people who are being listed by the CRBs for default on their loans. The health sector is something that we can actually tackle easily because every month the deductions are happening. Where is the money going? Because if I am going to put in my money to a facility, to a hospital, like they need to get an MRI, they need to get lab equipments, they need to get reagents and all that, because I know this money is going to come in at some point. Yeah. The moment that money is not coming in, it means then even the private hospitals are going to close. So if private hospitals that are supplementing the government hospitals close, and the government hospitals, the doctors are on strike, yeah, what happens to our health as a nation? Mm-hmm. If you want to tax me and I am not healthy, what are you going to tax out of me? So we need to come up with proper mechanisms. Okay. We have tried, yes, as the Medical Credit Fund, to support these healthcare, private healthcare practitioners in the country, to ensuring that they have the necessary working capital to afford the drugs that they need, because we know out-of-pocket is very minimal. So a lot of this comes in from insurance. We expect them to be reimbursed by the insurance companies 30, 60, 90 days on our worst case scenarios. Yeah. We are talking of a scenario whereby 9 months down the line, money is not forthcoming. Every month, a hospital bills, say 500,000, but they are paid 50,000. 450 is carried forward. What do you do with 50,000? Do you pay staff? Do you buy drugs? Do you replenish your equipment? What do you do? So it's now becoming a dilemma to all of us.
So just for clarity purposes, what is your role exactly as Medical Credit Fund?
Thank you, Trevor. Medical Credit Fund is a blended impact finance that offers debt capital in the health space to private health SMEs. We realize that medical equipment are a bit difficult to obtain. Mm-hmm. We realize that a majority of the financial institutions do not understand the operations of hospitals in this country. And they are then treated as being specialized, and nobody wants to commit their funds in assisting them. A majority of us lack the resources to put up these facilities. So Medical Credit Fund comes in to assist the health SMEs that we have in the country, the private ones, to be able to get the simple working capital solutions that they need to continue operating as they wait for insurance reimbursements, to help them acquire the complex medical equipment that is needed, the MRIs, the CT scans that everybody shies away from obtaining. Yeah. Currently, in our financial sector, our lending is more collateral-based. And if you go, for example, to a hospital to offer them financing, the first question a financier will ask you, what collateral are you providing? So the moment a hospital says we are getting a CT scan, and that's what we're thinking is, all the financial institutions tend to shy away from that discussion. Mm. So the question is, who bears that gap? Who assists the health SMEs to be able to actually be getting this capital that they require? That is the role that the Medical Credit Fund is actually coming in to do in our economy, to supplement what the government is doing in the public sector, but also to ensure that the private sector is able to move.
Okay.
My friend Muthusi here probably in future will want to own a hospital or to start a clinic. He will be my right candidate. And if he's being frustrated now as we are speaking, then it seems like also the Medical Credit Fund is going to be frustrated in future. So I have to ensure that Muthusi here is well taken care of so that I know I'll have a client who is coming to me tomorrow.
Okay.
But if he's frustrated, I'm equally getting the frustration.
Okay.
Thank you.
Let me bring back Wachira on this. Wachira, so what is the deadlock here? What is the issue? Because there's been a lot of direction from the court as well that we should sit down and agree. You've had several meetings. What is the main bone of contention here?
I think our main problem is priority. Because, Trevor, you know, as a leader in the labor space, there are some things that we cannot enter into. And as I said earlier, because we have 10 demands. One of them, and by the way, we have no new demands. All the demands that we have put forth are from the agreements that have been there in the past. The first one being that in 2021, through a presidential level interministerial committee chaired by the Labour CS by then Chelugui, agreed and gave us an enhancement of the risk allowance from 3,000 to 15,000. And I have heard some people say that probably that is a 500% increment. But Trevor, you know, when you're talking about risk in health sector, there are three things we look into. We look at knowledge, we look at time of exposure, we look at the environment under which you work. So the clinical officers in this country, we are the people in the outpatient. So we actually see basically everybody who comes to hospital. We are the ones who see them and then decide whether to admit them or they go back home. And when we admit them, then they are seen by the medical officers in the wards. So when it comes to knowledge, the way that consultation is structured so that you ensure privacy and confidentiality is that when you come in, I have to be with you for about 15 minutes in an enclosed room. So number one, I don't have the knowledge of your condition. Number two, I have to be with you without knowledge of that condition for 15 minutes. And then the environment is that I'm in an enclosed room. So it puts us as at the highest risk actually of contracting the infectious and contagious diseases. And that is why right now I think the number of clinical officers with multi-drug resistant TB has really increased because of that issue of knowledge. And then once we diagnose, now whoever takes after that, we warn them that probably this might be an infectious disease. And that is the justification that led us to be given the enhanced risk allowance of 15,000. The CBA we have negotiated since 2019. We have gone through a cycle, because a CBA cycle is 4 years. We have gone beyond the cycle of the CBA, despite the court directing and the employer ignoring this. But now, Trevor, when it comes to some issues that are actually against the law, and that is what I'm asking, when you are told to sign a return to work agreement, then says that we are going to continue engaging the contracted staff, including the universal health coverage, the CHAP, the national TB program, in contract, that you don't actually need to be a lawyer to see that they are against the law. How do I sign that? Those are things that I cannot sign. And that is one of the biggest issues that we are having. And probably that is holding us back from signing a return to work agreement. The issue of interns. And I want to add to what my brother here, Muthusi, said. You know, the interns in the health sector, these are people who are qualified. It's not that they are not competent. The only reason as to why we do internship is because a human being is not like a machine. You are qualified, yes, but before we allow you to see a patient independently, we want you to see this patient under the supervision of an experienced colleague, so that by the time we are giving you license and now you can independently do that, then you'll have enough experience and we are going to know that you are safe for that patient. But you can see they have reduced for doctors, I think, from 206 to 70. For clinical officers, because we have two categories, the diploma and the degree, they have reduced for the degree from 115 to 50,000, which is 65,000.
Yeah.
And that is why we told them not to pick the letters. And of course, it's an issue that is still on the table. And one of the contentious issues as to why we have not also been able to agree with the Ministry of Health. What is happening, Trevor, and we know the bigger scheme, this is just the tip of the iceberg. Once the interns are going to accept this lower salary, then once you qualify, if you are paid 50,000, why wouldn't you accept 100,000? So it's the reduction of wages in the health sector.
So you see it as a reduction across board?
Yeah, it's a reduction of wages in the health sector. That is the bigger scheme. And the good thing is that I think the CS for public service, CS Korea at some point probably hinted to that they're even looking at putting people on contracts.
Yeah.
But that's another illegality because, and sometimes I never understand why the government only uses the law when it is convenient to them. Trevor, when it comes to the issue of contracts, because it's also a legal issue, contracts are provided for under the Employment Act and also under the Public Service Commission Act, while the Employment Act talks generally, including the public and the private sector, about the contracts and how you can enter into them and the categories of contracts, from the casual contracts, from the short-term contracts. When it comes to those in the public sector, the Public Service Commission Act provides very clearly on how the public sector can engage anybody on contract. And it actually states that for you to engage a person on contract in the civil service,
Yeah.
you must justify that they cannot be employed under any other terms, and that is permanent and pensionable.
Okay.
And then it goes further to say that for you to engage anybody on a short-term contract or casual contract, you must follow a framework that has been developed and shared out by the Public Service Commission.
Okay.
That framework is out. The framework talks about that whatever you're engaging them for a short-term contract, it must be either a specialized service requiring consultancy,
Yeah,
or something that is going to probably end anytime soon.
Okay.
That does not apply to UHC because UHC is not a project that is going to end in a few months.
Okay. Odipo, what will it take for you to return to work?
Trevor,
What are the irreducible minimums? Because you're saying that you've not had a sit down with anyone, nobody has consulted you. And
our irreducible minimum is recognition agreement.
Okay.
Because that is the key that is going to unlock whatever that will come after that. We have a lot of issues, and I don't really understand why the government do not want to sit with us down. To my thinking, medical laboratory officers in this country have undergone a lot of injustices. And injustice, I mean that the kind of workplace that these people are working in has never been taken seriously. If you look at a ruling that was done in 2019, Judge Macau clearly gave an order for the Minister of Health and county governments to stop engaging non-medical laboratory officers in doing medical tests. 2019 to now, that's around 5 years. We are still having the non-medical laboratory professionals doing medical laboratory tests, and more so the HIV testing that is currently being done in the country.
So people who are not qualified are doing the tests?
Who are not qualified are doing the test.
Okay.
And this is the bone of contention. So I tend to believe that the reason why these people are shying away from giving us maybe the recognition agreement is the shift that is going to come with it. Because we are not going to allow people who are not qualified. And by the way, I've been saying that these people are engaging Class 8 dropouts, and I'll repeat it, that the government, through NASCOP, is engaging Class 8 dropouts in HIV testing, which is very sad. Today, NASCOP is giving Class 8 dropouts and Form 4 leavers a 2 weeks training. And they purport to license these people to go and do HIV testing. NASCOP, as far as I am concerned, has no any authority to license professionals in this country. They're supposed to coordinate HIV services in the country and not to license. But currently, if you go to any hospital and the person you get there, they will tell you that I have a license from NASCOP.
Is that the reason why the government finds it easy to ignore?
I tend to believe so, because the government really, what they are doing is about cheap labor. And if we don't be very careful with this government, they will start to put workers into slavery.
Okay.
And the article of under the Constitution is against the citizens of this country being put into slavery.
Okay.
Because if you find that you want to employ workers and pay them half of what is approved, that is slavery. And that is what is happening in most of these counties.
Okay.
And to be specific, I'm talking about a county like Siaya, a county like Kakamega, a county like Kisumu, a county like Mombasa, where our members are working with as low as 15,000 Kenya shillings. A watchman currently is not even being paid 15,000. And the minimum wage bill has risen to around 16,000. But these people find that it is very comfortable for them to pay a medical laboratory worker 15,000. So I'm tending to believe that the reason why these people are shying away from engaging us and giving us this recognition agreement is because of these injustices.
Okay.
Yes, because as a union, we are not going to allow any injustice to be done to our member, even if they don't give us that recognition agreement. I want to be very clear with them.
Okay.
They can deny us that recognition agreement, but so long as this union still exists, we are not going to allow any of our members to be put into exploitative terms of service like these ones that we are currently having.
All right.
Yes.
Ntusi, you know, there's been an argument that there are some interns in different places who being paid 70,000 shillings would be a miracle. Why is this not enough for medical interns?
Well, we've spoken about, or rather, we've given you a clear picture of the value creation that medical officer interns, pharmacist interns, and dental officer interns actually bring to the economy and to the country. Bearing in mind that in maternity, or rather when it comes to cesarean sections, interns actually generate, if you are to accurately put it, between 1 to 2 million in 48-hour shifts. And that's in 48 hours. Whereas at the end of the month, the agreed upon rate that was actually deliberated by SRC, the Ministry of Health, and the union in 2017. Because you see, the issue of pay, it's not usually decided on a whim. It's not a whimsical figure. It's actually not arbitrary at all. I mean, there are a lot of considerations that go into it. You have to compare the value that people bring, ideally, the value creation. You have to compare the economic compensation in other countries as well. So this was actually a figure that was arrived at in 2017, and it was at 206. And if you look at inflation, and if you're to actually adjust for inflation, the amount of money that is actually being given now, we should actually be talking about an increment. But given that that's not, or rather, given that that's not what the government proposed, because it proposed 70, we're now saying, okay, let's stick to the 26, stick to the CBA, because that's ideally the legally backed document that was supported by the previous government, and there is continuity. And also when it comes to now the difference, ideally, between the interns, because you've broached me about it.
Because that's where people,
Yes.
that's where the main bone of contention
Yes,
is.
yes.
People always say that other interns don't need half of that. So why do medical interns need more?
Okay. And again, I'm comparing and contrasting, and I'm not undermining my colleagues who are other professionals. Let's take law, for example. The area of practice in law is a court, right? The area of practice in medicine is a hospital. But law takes approximately 3 to 4 years. And how many times do lawyers go to court while they're students? Is it every day? Is it weekly? Is it monthly? You see, you can't even compare. With medical training, we basically go to the wards each and every day for 6 years, from morning till evening. And it's interesting. I mean, the amount of preparation and attention to detail that we're actually taught, because it's quite tactile, our training. I mean, given the challenges of infrastructure and equipment, we're actually taught to diagnose diseases by ideally touching and just being able to palpate a patient and know. So you actually use other equipment to somehow guide the diagnosis. But this is the level of complexity that we're talking about. When it comes to surgeries, when it comes to preparing patients for operations, when it comes to managing people who come in with accidents, these are things that we're exposed to in our 3rd year all the way to our 6th year. And each and every day we go through that. Each and every day you're faced with life and death decisions, not only as a student, but even as a doctor. And now when we actually graduate and when you're interns, my brother, Peterson Washira, has spoken about the supervision. It's actually a bit different when it comes to medical doctors, if I'm to be completely honest. I mean, 95% of the well over 5,000 hours that we do our internship weren't supervised. It's only when it comes to truly complex procedures that you actually reach out to our consultants and actually they guide us. But when it comes to the mundane, the daily, what actually happens on a day-to-day basis, from 8 a.m. in the morning till 8 a.m. the next day, because we do man shifts at night. You're there alone, manning the hospital, you're in the outpatient division, patients are coming in because of accidents. You had floods, I mean, disasters. You have people coming in because of possibly pregnancy complications, and you have to attend to them. And you're the person who's actually making the decisions. You're the one who's planning. You're the one who's preparing the patients, informing the family, going into the procedure, and actually conducting it yourself. It's like you're literally carrying the profession. And to say that, I mean, I understand it. I mean, maybe this entire conundrum is simply because of the intern misnomer. I mean, we are medical doctors. We are medical doctors, and we've earned it. And we yearn to treat our patients. We yearn to treat this country and our people. It's something that we've been deciding each and every day and reinforcing it, regardless of the challenges that have been held at us in medical school.
So the difference here is you're not ordinary interns.
No, the difference is the complexity. No, it's okay, brother. I can explain myself.
Yeah.
The difference is one, the value that you actually bring to the table, which I've highlighted quite clearly, with the complexity of the procedures and even the costing to it.
Okay.
2, the arrival at these salaries is actually done in an empirical way. It's not arbitrary. It's not us just deciding that we need to earn this. No. People sat down, did research, economists were there, policists were there, doctors were there, and they actually arrived at those figures in 2017.
Okay.
But bear in mind that with inflation and with basically the increase in the cost of living and even the austerity measures, it would be quite punitive to expect us to ideally create the same value, do the same work, and now workload is even increasing.
Okay.
The population is increasing. We're handling more patients every day. We're handling more work every day. The economy is also suffering. Okay. We have dues. And there's also another challenge that I've forgotten to point out. And then there's also now the complexity and the finance and time aspect of medical training. Medical training is extremely expensive. If it weren't for the government, we wouldn't be able to study medicine. No, it actually sponsors us. And it's even subsidized for people who sponsor themselves. But even then, we still have loans that we've taken in our undergraduate studies. We need to furnish those loans. As we progress, we also have postgraduate studies. And now government has scrapped off postgraduate training and sponsorship. So we really need to have a fallback plan, some savings that can steer us into the next phase of our profession.
All right, let me bring in Kennedy first. Washira, I know you want to jump in, but let me bring in Kennedy on this. Kennedy, at the end of it all, the main issue here is around finances. And you've mentioned the support that you give to private health facilities. Is there a plan to also help public health facilities as MCF? And are you looking at the human resource part of it? Is that part of the things that you can fund? Or is that not one of them?
Trevor, other than financing, there are other aspects in the health space that we also focus on, because financing is just one of them. One key aspect in our work is actually quality improvement in the health space. Just like Mudusi says, he spends the whole day in a hospital, the whole day across patients, sitting with patients. So what do we do to ensure that the hospitals that we are having in this country are operating within the right standards? So that if I'm coming in as a doctor, or if I'm coming in as a patient, for example, I don't come in with malaria and I walk out with 4 other ailments. So one of our key components in our work is actually quality improvement through an accreditation model. This we do, yes, in the private sector, but we also do the same in the public sector. Our organization actually does accreditation of health through standards that we call safe care, whereby it's not about the size of the hospital or the location of the hospital, but the standard of care that's actually happening in that facility. And this we do across all the sectors, both public and private. We want to ensure that our healthcare workers are doing the correct thing in the right manner. If I can take you back to when COVID hit this country, you remember scenarios where actually doctors and nurses were running away from the hospitals if Kennedy walked in and said, I have COVID. Nobody knew how do you start handling this patient. So quality of care is very, very critical. It doesn't matter whether it's private, it doesn't matter whether it's public. It doesn't matter the location. It could be a small clinic somewhere in the rural area, but they must first of all be doing the correct thing in the correct manner. And we do this to ensure that we help doctors to run their hospitals in the right way that's required in this country. Our quality standard accreditation is borrowing from international standards, yes, but we understand that we operate in a country called Kenya. So we localize them to make them very simple for the understanding of everyone. Simple things as waste segregation. You know that in a hospital, you don't just lump everything to one dustbin. There's something that goes here, there's something that goes here, there's something that goes here. This is training that we offer and handhold the hospitals to ensure that they do that.
Yeah.
Over and above quality, there's technical assistance. Mudusi has just mentioned that he's spending 6 to 8 years in medical school. Eventually, when he will start a clinic, the clinic will grow. He'll have an accounting department, he'll have a HR department, he'll have a housekeeping department. Remember, he's trained as a medic. He's not trained to look at that business as an SME.
Yeah.
So if I'm providing him with finances, if I'm helping him to improve the quality of care in his hospital, I also need to change his mindset and start looking at that as an SME. He's now running a business. Yes, it's a hospital, but at the end of the day, it's a business that needs to pay him back. He has to recoup all the resources that he's put in there. So I provide him with financing, I provide him with quality training, and I also offer him technical assistance to make him better. So the healthcare providers that we deal with, actually what we do is to make them bankable.
Yeah.
If I can use a simple layman's language.
Yeah.
We make them bankable so that now financial institutions can come and say, yes, we can partner with these people. They are able to take these loans. They are offering the best quality. I'll not be scared if I walked into this facility in the village. Yeah. I'll get the right treatment as opposed to traveling 500 kilometers to Nairobi.
Yeah.
Because only the best hospitals are purported to be in Nairobi.
Yeah.
So we have to ensure that even the hospital in the rural areas are well supported to offer the best quality of care. Such that if I receive a call from my village, I don't need to worry about shifting that person from the village to Nairobi. I need to know that there's a hospital right next door that has been well equipped.
Yeah.
It has the right equipment, it has the right drugs, it has the right quality of care, and it's offering the best care to that person in that village.
What is the range of financing here, minimum to maximum? And then also, are you worried when the submissions from maybe NHIF is not coming through? Is that a point of concern?
Trevor, let's look at the range of financing. I do loans as little as 10,000 shillings. Because there could be a pharmacy next door that just requires 3 cartons of drugs to survive a week. They don't need so much. They don't need to give me so many things. They just need 3-4 boxes to survive a week. I need to be able to play to their league. There is another big hospital that requires to construct and equip a radiology unit. So I move from as little as 10,000 Kenya shillings all the way to 500 million Kenya shillings, just to ensure that I take care of the needs of everyone, from working capital, from equipment, from construction, from expansions, from acquisitions, everything in the health sector. I have to come up with products that will suit everyone operating in the health sector. Currently, we're even having private nursing schools that are coming up. They also need to be equipped with classroom equipment, with the ones that they use for demos for their students, and nobody is actually taking care of them. Currently, we are having health management system providers, the techs. They are doing something in the health space. I'm taking care of all these people just to ensure that they have the right resources that are needed. But my worry is coming in when there are delays in insurance. Why is this? Because in Kenya, health is paid through 3 ways. One is out of pocket, which is very minimal. Second is private insurance, which only applies to some of us who are lucky to get employment in this country. And thirdly is what we have like the universal health coverage, which is actually a good thing that was started in the previous regime, and it was already taking effect because now everybody had this access to health as a result of NHIF. Hospitals, be it private, be it public, relies on those 3 modes of payment to be able to survive. And when a patient walks in, he needs to see a consultant, he needs to go to the laboratory, he needs to go to the pharmacy and walk out with drugs. And yet, all these services will be reimbursed at a future date. So for them to be able to do this, then I have to provide them with the capital they need, such that if Kennedy walks in, he sees the consultant, he goes to the lab, he walks out with the drugs. So if you delay the reimbursement process, it means my loans are affected. If my loans are affected, it means I might as well also close down. Which means now the much needed capital, the much needed resources that are supposed to be circulating are stuck at one point. Because if it was moving from NHIF to the hospital, to me, I could be able to give it to the next hospital. But if I give it to one hospital and it gets stuck there, I have to write off that loan, or do I have to do? The moment I write off that loan, they are my employees who are at risk. Who are also supposed to be paying back the taxes to the government. You get? So it's a ripple effect that needs to be actually cross-checked. Yes, I appreciate that there are always transitions. And the transition from NHIF to SHIF is a good thing. But the question arises whereby I have claims worth 20 million with NHIF, which is actually becoming moribund. Is it end of June or July? Is ceasing to exist. So hospital owners are asking themselves, so if NHIF ceases to exist in June, and I have claims dating back 10 months have not been paid, I have loans, I have staff to pay, I have bills to run in the hospital for the hospital to keep running, what happens? So during this transition period, our appeal to the government will be, as private players in this, please ensure that there is continuity. In as much as we are moving, yes, but let there be a continuity such that these gaps do not exist, because coming out of these gaps that will have been created by this transition will be too catastrophic for our economy.
There's a lot of feedback coming through. Let me read some of them really quick, and then I'll come to each and every one of you, just a minute each for closing remarks on solutions going forward as we finish up on this. Just 1 minute each, but let's see what you're saying online. Gabi says, enraged with increasing death in public hospitals, the government of Kenya has a conditional and moral duty to provide quality health care to every Kenyan. Over 500 people have died over the ongoing doctors' strike. The doctors should go back to work immediately. They're already actually back to work. The doctors are back to work. The clinical officers and the lab techs are not. Godi Baraza says, instead of the government spending heavily on unnecessary activities like renovating the state lodges and other lavish expenditures, they should have ensured that the doctors' welfare is taken care of. Ole Shonko says, it's clear we are a reactive nation on critical issues. Clinicians must advocate for their rights and support intern doctors. They've been shortchanged, and this lack of motivation impacts their work. Engineer Lazaro, economists should air their views freely without fear or favor, but taxations will scare investors and give our neighbors good advantage to grow their economies. President Ruto should learn from history of Amin Dada. Bob Otieno says interns and other medical practitioners are on strike because they thought KMPDU had their interests when they were negotiating with government on a return to work formula, only to realize they were betrayed and abandoned on the table. Okay? Frank Orinde says the government is so insensitive to the human capital, yet these are the same people who should grow the economy. When it comes to paying workers well, there's no money. And when it comes to extravagant expenditure, billions are released. Oppression is what they, KK government, know. Okay? Sir Nixon says government must make an effort to meet these striking clinical officers. That's how healthy negotiations start. The most critical thing in a negotiation is to get inside your opponent's head and figure out what they really want. Okay? Lilian Sioyo Mweshimiwa says the clinical officers and lab technicians should have a structured dialogue with KMPDU and COG for their issues to be amicably resolved. The government clearly showed commitment to ending the stalemate in the healthcare system. Okay, Ndusi, I'll start with you on closing remarks. So what are you looking at as the solutions going forward? And one of the viewers said that as medical interns, you're demoralized because you feel betrayed. Is that true? And 1 minute for closing remark.
Yes, well, the embers of the fire that started this whole strike, which is ideally the internship issue, the embers are still burning. And an allusion is made to history. I believe history does repeat itself, but you need not make the same mistakes. In 1994, a similar scenario happened, whereby the young medical doctors then, and then the interns, weren't compensated adequately. And most of them chose to jet outside of the country, and there was a serious brain drain that led to the diffusion of medical doctors from Kenya to Namibia, the UK, Australia, the United States, and other countries. But we don't want that. We, as the young doctors in this country, love this country. We've been studying for this country, we've been training for this country, and we yearn to get out and serve. And I'm imploring the people of this great nation, our leaders, and the President, His Excellency, to actually compensate us adequately. We are imploring them to stick to the collective bargaining agreement, and if anything, they should actually increase the salary once they sign a new one for the incoming crop of doctors who are still in medical school, going through the trenches of war, so to speak.
All right. Yeah. Wachira, 1 minute, closing remark. Your rallying call to government and COG.
Thank you, Trevor. I think for us as clinic officers, we continue on strike as protected by courts. We have about 5 irreducible minimums. The enhancement of risk allowance must happen. We must harmonize the terms for the UHC and absorb them. We must harmonize the terms for all those on contracts. We must ensure that every member has a comprehensive medical cover. And the last one is that we must also ensure that everybody is promoted and redesignated.
Okay.
My final remark is to the CS Health, CS Nakumita, because we have been looking for her and we have not been able to have a sitting with her. There is exclusion that is happening under the Ministry of Health at Afya House. Number one, when it comes to the SHA regulations and the team that was put in place, there is exclusion of all the other regulators, the Clinic Officers Council, the NCK, the lab, and they're only consulting the KMPDC, and they want to appoint the KMPDC as the only one to accredit facilities, which is against the law.
Okay.
Number two, there is a quality of care bill that we know that is being handled with a lot of secrecy and has been taken to Parliament, that is also going to exclude some of the professionals from the healthcare and the UHC, and that is not the spirit of carrying everybody under the UHC. Right. So we want to have a sitting with her so that we can discuss these issues, because we don't want to start fighting, because we will not allow that to happen.
Are there more protests coming?
Yeah, of course, every Tuesday we are having our demonstration until the strike, of course, is suspended.
Okay.
We usually don't protest as health workers, but let me reiterate that we don't want to be on strike. The most comfortable place for us is with our patients, and we are willing to go back to our patients anytime our grievances are sorted.
All right, Kennedy, closing remarks.
Trevor, it's so sad that in this day and age, hospitals are being auctioned due to lack of unpaid bills, and yet they have offered this service to the wananchi. Wananchi who've been deducted monies to pay for universal health coverage, and yet these monies are being held and are not coming back into the economy. My appeal will be for the National Health Insurance Scheme to release funds to hospital, just to ensure that they also continue in business. As we budget to revamp our state lodges, as we budget to do XYZ, let's not forget the health sector. It's a very, very critical factor in this country.
All right.
We should not be sending people to countries outside, and yet we have facilities that can actually accommodate everyone.
Okay.
If they could only just release the funds to the hospitals, and life will continue on as usual.
All right. Finally, Odipo, closing remarks.
Thank you, Trevor. Now, medicine without the laboratory is witchcraft. That is a point that everyone must know. Number two, the Minister of Health and the county governments should start to understand that you cannot exclude medical laboratory from the equation. They're equally important. They prevent guesswork in hospitals.
Okay.
So it is time they start engaging us. 3, I appeal to my members, please stay at home. Do not go back to work, because it is only through this that we are going to liberate ourselves from the bondage of slavery that we've been held on for quite some time. Finally, Trevor, I will want to address the CS Nakumicha. There's a lot of mess up of how medical laboratory services are run in this country. I want to tell her that it is her responsibility to ensure that this country gets quality medical laboratory services. And that cannot happen when we have a quack sitting at the Division of National Laboratory.
Okay.
It is an injustice to the people of Kenya. It is an injustice to the medical laboratory fraternities.
All right.
Then, I also want to tell her that the issue of Class 8 dropouts, and this one now goes to the wananchi, the issue of Class 8 dropouts. We have a licensing body that licenses medical laboratory officers. That is KMLTTB.
All right.
Please, if you go to any hospital, any VCT center, ask that person testing you to give you his or her license from KMLTTB.
Okay.
If that person cannot produce that license, please do not allow yourself to be tested by that person, because that is a quack. And the ministry should stop giving Kenyans lip services through quacks.
All right. Thank you so much for making time this morning. Peterson Wachira, Kenya Union of Clinical Officers Chairman; Nicholas Odipo, Kenya National Union of Medical Laboratory Officers Chairperson; Dr. Mwinde Ntusi, Medical Officer Intern; and Kennedy Okongo, Medical Credit Fund Director, East Africa. Thank you all for making time for us, and thank you for all the feedback that you've sent through. Coming up next is Level Up Friday with Ben Su, and he has quite a number of DJs on the decks there. There's DJ Ronix, QT, and Ibu Rabban, I think. Main names that I may not even be able to pronounce. All right, that coming up next. Bye for now. My name is Trevor Mbija. Enjoy your weekend. See you soon.